Hello, this video is my attempt to make a recording of what is an interactive session with the medical students looking at the anatomy on chest x-rays of the mediastinum. This session normally involves the students drawing on images on my iPad and projecting to the screen, so forgive me if parts of it don't translate terribly well. What I'm going to be doing is showing you examples of normal mediastinal structures on a chest x-ray, showing their correlates on a CT scan so you understand what makes that line or that opacity, and then we'll look at some examples of abnormalities in that area so you know why it's important to know about these. So let's get started. The important thing to remember from the outset is that every line on a chest x-ray, with the exception of the osseous structures, is formed by some interface between air and soft tissue. If you have soft tissues up against soft tissues, you won't see that line. If you have air up against those soft tissues, you're going to see it. So we're going to start at the top, at the most cranial end, and work our way down. You'll see that in the top of the mediastinum, we have some curvilinear structures like this. Depending on the age of the patient, these might swing out over the lung apices or not. When we look here at contrast-enhanced coronal CT through the mediastinum, we can see what makes those opacities. It's the interface between the air and the great vessels here. So we have the superior vena cava here, and we have the brachiocephalic vein there. Sometimes some of the arterial structures can end up being very ectatic and swinging across as they come off the aortic arch in addition. And looking on an axial CT, it's this interface here between the air and those soft tissues that we're seeing on a frontal radiograph. X-ray beams coming from here, we're looking at these edges. Let's move down a little bit further. No prizes for guessing that this is the trachea, but you'll see that there is a thin stripe of soft tissue, shouldn't be more than about 5 millimeters thick, that lies between the trachea and the lung coming in. I'm going to zoom in and erase my lines in just a minute. And there is a similar but thicker one on the left. So the line I'm talking about is this one here, and it is the right paratracheal line or the right paratracheal stripe. Now let's look at a CT scan. So we've got the trachea in here, and you can see that if you look to the right side lateral to the trachea, there isn't a whole lot of stuff. Now this is being shown on a mediastinal window, so I'm just going to change for one moment over to a lung window to show you. So this is a lung window, and you can just see there's just a little bit of fat running in that right paratracheal region, but virtually, as well as the tracheal wall, but virtually nothing in there. The only thing that we do see there are these little grey ovals, and those are normal lymph nodes. If ever we see little oval grey things, they're usually lymph nodes. So they're normal right paratracheal lymph nodes, and that's why we pay attention to anything. So anything that can produce enlargement of lymph nodes, and some examples in the thorax would be lung cancer, lymphoma, sarcoidosis, metastatic cancer of any type, can all enlarge those lymph nodes. So that's why we pay attention to the right paratracheal stripe. Now let's see some examples of this. This is a patient who has sarcoidosis, and what we can see here is a big, thick right paratracheal stripe, clearly bigger than 5 millimeters. They've also got a lot of stuff in the left paratracheal region coming up against the aortic arch, and they have some hyaloadenopathy, at least on the right, so sort of classical inverted Y appearance, as it's called, of sarcoidosis. Here's a patient who has had previously treated right apical lung cancer. It was treated with radiotherapy. You can see some scarring here and some elevation of the right the right hilum here. This is the baseline, and then this is a follow-up 6 months later. And what you can see here is now there's thickening of the right paratracheal stripe, and this was due to recurrent adenopathy from recurrent malignancy at this site. So let's move south a little bit. As you come down the bottom of the right paratracheal stripe, you'll see it elongates into a teardrop-shaped structure which lies right above the right main bronchus. Now you can see here that it's superimposed over the superior vena cava, which we'd seen before, so that's going to give you a clue. I'm just going to show it to you again here, this little oval structure here, and that is the azygos vein. The azygos vein comes up from the abdomen, it runs alongside the esophagus, and it comes up and plunges directly anteriorly right above the right main bronchus. Here's part of a MIT from a 3D CT angiogram, and if you can see, this is looking from the right side of the patient. So here is our aortic arch, and here is our azygos vein. It's coming up from the abdomen, it's running close to the aorta, and then it dives directly anteriorly, and it's draining into this structure which is hidden behind everything here, which is a superior vena cava. So if you imagine, what we're seeing is the end-on azygos vein, so it's kind of coming out into the screen towards us. Seen on a transaxial CT, it has its horizontal course, and then it will dive into this structure here, which is the superior vena cava, so we're seeing it that way. Now, what lives in that space? Well, we've got the azygos vein itself, and then we have at least one of these little grey oval things, i.e. a lymph node. There's a normal azygos lymph node. Now, generally speaking, the azygos vein shouldn't be more than about 1 centimetre across in its short axis there. So what can enlarge it? Well, anything that enlarges the azygos vein, so things that cause increase in right-sided heart pressure, so pulmonary emboli, congestive cardiac failure, pericardial restriction, anything that increases that pressure will distend the superior vena cava, and it also distend the azygos vein. There are also some unusual anomalies which obstruct drainage of either the head via the superior vena cava or the abdomen via the inferior vena cava, and nature finding a way will tend to send the blood via other routes, in which case it will send it via the azygos, and the azygos can get big and fat in that circumstance also. We said, however, that there were normal lymph nodes there, so guess what? Anything that causes adenopathy can produce adenopathy of that azygos nodal area. This is a patient who has lymphoma. You can see that she has a big fat lymph node sitting right in the azygos. She's also got more adenopathy, which is lying against the aortic arch, a little bit more difficult to see there. And on this frontal chest radiograph, it's really this which is going to catch your eye and make you realize that there is an abnormality there. That's probably more like 3 centimeters than 1 centimeter. Here's another patient who again has a big fat azygos node there. Here it is here. I forget what their primary tumor was, but this was a metastatic disease. Now let's look at the other side of the mediastinum. Now here we have our aortic arch, and then here is our main pulmonary artery with our left pulmonary artery coming out. Now in between our aortic knob and our main pulmonary artery is the AP window, or the PA window, depending on which side of the Atlantic you come from. The AP window should be concave, not convex. Sometimes in young women we can get it kind of a little bit bumpy there, but generally speaking that is going to be concave. On the lateral chest X-ray, here's our aortic arch, here's our left pulmonary artery, which we'll see about in a minute, and in between the two is going to be the AP window. So what lives in the AP window? Well, not a lot is the answer. Fat and little grey oval things, which are lymph nodes. So again, anything that can produce enlargement of lymph nodes in the chest, lymphoma, metastatic cancer, lung cancer, sarcoidosis can produce an enlargement of that AP window, and those lymph nodes are going to start to bulge out like this. Another tumor to look for in this area is small cell cancer of the lung. This has a predilection for liking the mediastinum, and often you can have this big tumor which just starts to poke out the AP window before you notice it. Also in the AP window level, just so that we have completeness here, this is the esophagus. This is a normal esophagus, and just to remind you, that was the azygos vein we saw just now. Ascending aorta and descending aorta. What's that vessel going to be? That's going to be the superior vena cava, which we already talked about, is going to be seen nicely at the level of the azygos. Just to show you on the coronal CT, so we have the aortic knob, we have the main pulmonary artery, there it is, our lodic concave AP window. And here's a patient with an abnormality in the AP window. This was a small cell cancer of the lung, and you can see coming out this big bulge here that shouldn't be here. But, you know, really not outrageously obvious on the chest x-ray. Just take off the lights here so you can see it. And here it is, much clearer seen, obviously, on the CT. All of this is abnormal. This was actually a big and inoperable tumour. Let's move down now to the pulmonary hilar. So, obviously, this is the right hilum, and this is the left hilum. Now, you may notice that in all patients, the right hilum should be under the left hilum, so it should be more caudal to it. You know, it's probably about a 10-15 degree difference if you kind of like to measure things between the two. The reason that there is that difference is because the left pulmonary artery goes over the left main bronchus, where the right pulmonary artery goes under the right main bronchus, so it kind of pushes them into that position. Now, what about on the lateral chest x-ray? Well, I'm showing you a patient who has pulmonary hypertension, so they have big fat pulmonary arteries, so I can show them to you easiest, but you should be able to see them on normal ones as well. So the way to remember this is the aortic arch is on the left-hand side of the patient. If you look under the aortic arch, you will see a mini aortic arch, and that is the left pulmonary artery, and it's sweeping backwards. Okay? The right pulmonary artery is inferior and anterior to the left pulmonary artery, and that one looks like an oval, similar to we saw with the azygos vein, because it's coming out towards us out of the screen, which you'll see when I show you a CT in a moment. So just to show you again without the lines on it, the left is going backwards, it's your mini aortic arch, and the right is anterior and makes a circle. So here they are on a CT. So CT cut A is slightly more cranial to CT cut B. Here is the left pulmonary artery sweeping backwards. Here is the right pulmonary artery kind of coming out to the side. So if you imagine on a lateral chest x-ray, this one's going to look like a circle, and this one's going to look like a tube. And on a coronal CT, just to show you that normal angle between the two pulmonary arteries. And that relationship is important because if you see that right pulmonary hilum pulled up, so it's at the same level as or even higher than the left pulmonary artery, that is usually due to volume loss in the right upper lobe. So sometimes that can be the best sign of right upper lobe atelectasis. I love these 3D CT angiogram maximum intensity projections for showing you these things. So this is a patient who's had a CT with their heart full of contrast, and the computer stripped away everything but the contrast. So here we're looking from anterior, here we're looking from the patient's right, and here we're looking from the patient's left. So here is the ascending aorta coming out, and this is abnormal. This is wide, and this patient has an ascending aortic aneurysm here. I'm going to go to just focus on the pulmonary arteries here. So here we have our aortic arch here, and we have our main pulmonary artery coming out, swinging into the left pulmonary artery right under it. When we look from the right side, it's a little more difficult to see because it's all kind of coming out and branching right in front of you. We have lots of lymph nodes in our hilar, and they can get kind of difficult to look at on the frontal radiograph. Old films are definitely our friend here. And looking at those lateral chest x-ray and seeing it look totally normal there can be helpful, but this patient has bilateral hilar adenopathy from sarcoidosis. So here is a child who has right upper lobe atelectasis. Let's look here at the hilar. See? Here's the right hilar, here's the left. The right is slightly higher than the left. That tells us it's been elevated. So this here, which might have been misread as being an area of right upper lobe pneumonia, is in fact right upper lobe atelectasis. And this here is the elevated minor or horizontal fissure. So let's move down here to the aorta now. So we have our 3D MIP angiogram on the right. If you remember, this is not the same patient. This is actually a patient who has an abnormally enlarged ascending aorta, so I can just show it to you. The aorta arises in the middle of the heart, and it sweeps to the right before it sweeps to the left. So it's going to rise in the middle of the heart here, sweep to the right before it sweeps to the left. So aortic ascending aortic enlargement is only going to appear as a bulge here in the right side of the mediastinum. So the ascending aorta is going to come out of the heart here before it sweeps round. So this is where we will see enlargement of the ascending aorta. So this is a elderly lady who has a huge ascending and descending thoracic aortic aneurysm. This is breast shadow here, but this is aorta here. So it sweeps out and over, clearly enlarged, and here it is completely filling up the retrosternal space on the lateral radiograph, and then there's this massive, tortuous aorta on the way down. And just out of interest, we can see here on her axial CT, here's her ascending aortic aneurysm, here's her descending aortic aneurysm, and you can see that it's completely filled up that retrosternal window. While we're on the retrosternal space, let's talk about it a little bit further. So the normal retrosternal space should be this sort of lentiform, loosened area between the heart and the back of the sternum. Should only have fat, apart from in kids where you might have a thymus in it. In patients who had bypass surgery, sometimes this is all a little bit murky in there from scar tissue. So anything that's sitting in the retrosternal space as a bulge is abnormal. This bulge here, you can see it's definitely falling out of that normal lentiform shape as a bulge. Was an elderly lady with myasthenia, and if you remember, you might not be that surprised to know that this is a thymoma. So bulges in the retrosternal space might be a dilated ascending aorta, or it could be a retrosternal mass, such as a thymoma, a thyroid, lymphoma, and so on. Now let's do another couple of lines before we move on to the heart. If you go to the left side of the aorta, you'll see the aortic knob, and then as you go down, there's a line between the aorta and the adjacent lung. This is called the para-aortic line, or the left para-aortic line, or the aortic line, depending on where you come from. If we see a CT, we'll see why. So here's our aorta coming down, and we can see a nice soft tissue air interface that's going to make that line. We don't see the other side, the more medial side of the aorta, because you can see here it's up against the fat of the mediastinum, and this is the azygos vein right here. So there's no air against it to allow us to see that line. And here's the same thing on an axial CT. We have the lung coming in, goes around the lateral side of the aorta, and the line we're seeing is due to the X-ray beam hitting that interface here. And you can see there's no such interface on the other side of the aorta. So when's this line going to become abnormal? Well, it's going to become abnormal if you have anything up against the aorta that distorts that line. So you might have a mass, e.g. adenopathy, perhaps you have blood, as in the next case I'm going to show you where there's a ruptured aorta, but also anything that involves the left lower lobe of the lung or the left part of the lower hemithorax is going to lose that line. So if you have a left lower lobe pneumonia, or a left-sided pleural effusion, or left lower lobe atelectasis, you're going to have soft tissue against soft tissue. You will not have that air soft tissue silhouette, and you will lose that para-aortic line that you should be able to see. So here's a patient who has a traumatic aortic injury. Their aorta has ruptured, blood has tracked around the aorta, and you can see at no point down here do we see that para-aortic line. We lose the left hemidiaphragm as well because that blood has tracked into the pleural space and is lying posteriorly. It's also trapped up here and given us a big, thick right para-aortic line, an azygos area, as well as some blood up here. Here's a portable chest X-ray on a patient who has a left lower lobe pneumonia. And you can see here's the aortic line here, and boom, you lose it completely. You also lose the silhouette of the left hemidiaphragm for the same reason. With soft tissue against soft tissues, you'd lose that silhouette. Let's track out a little bit right here and see another vertical line. Now, if you look very closely in the middle of chest X-rays, down over the spine, you'll see another vertical line. So this was our para-aortic line, but there's another vertical line there. I'm going to blow it up and undo it in a minute so you can see it a little bit clearer. But that line is called the azygoesophageal line. Here we have the azygos and the esophagus together, and there is air up against them that produces a line. Here on a zoomed image, it's that line there. And just to show you on the axial CT, you have the lung on the right coming in, it's against the esophagus and the azygos vein, and that interface there with a X-ray beam coming from the front is going to make the azygoesophageal line. So what is going to make that abnormal? Well, let's think about it. We've got the azygos vein there, we've got the esophagus is going to lead down to the stomach. So if we rupture the esophagus, for example, with lots of blood, that's going to bulge it out here. If we had adenopathy in that area, it's going to produce a bulge out here. And then the esophagus is going to lead into the stomach. So probably the most common reason for a bulging at the azygoesophageal line is a hiatal hernia, because that hiatal hernia is going to come up into the mediastinum like this. And I'll show you. So here's an example. This is a patient. Now they've got a big old fat lung cancer, but ignore that. Here's the azygoesophageal line, and whoop, swings over to the right. And the reason it swings over to the right is because the patient has this big hiatal hernia sitting here. Here it is sitting behind the heart on the lateral study. All right, we've saved the heart till last. So let's talk about the cardiothoracic ratio, because a lot of people measure it incorrectly. So the cardiac, the numerator, you measure from here. You exclude any epicardial fat pads to here. That is your cardiac ratio. What's important, however, is that you don't measure the thoracic ratio at the same level. The cardiac ratio should be the widest part of the heart to exclusion of the epicardial fat pads. You should not measure the thoracic ratio here. You should measure the thoracic ratio at the largest internal diameter of the thorax. In this case, in this patient, it's there. Depending on the patient's thorax shape, and some people have fairly bell-shaped thoraces, you can overestimate the cardiothoracic ratio if you measure it at the same level as the heart. So what's a normal cardiothoracic ratio? Well, we usually take it as being 0.5 for a PA study. For PA and for an AP, we're going to take it as about 0.6. That's on an upright AP study, not a supine one. But just to let you know that this number did not come off the mountain engraved in stone, and there is a significant variability with age, where hearts normally tend to get a little bit larger, as well as body habitus, and there are a bunch of things that can make your cardiothoracic ratio look abnormal when it is indeed normal, but that will be a subject of another talk. But this patient clearly does have a big heart. If we're measuring it from here to here, the internal thoracic ratio from here to here is clearly greater than 50% of that. And this patient has pretty global cardiomegaly. Here's the left ventricle, and here is the right ventricle, and we'll talk about those in a minute, but its overall heart size is very big. On the other hand, there are a few things, and emphysema is by far the most common, which can make your mediastinum, your heart in particular, look too small. See, this cardiothoracic ratio is probably more like 0.25. Now, in this patient here who has emphysema, their mediastinum has kind of been stretched, so the volume of the heart is probably normal. It's just that the cardiothoracic ratio looks abnormal. Now, in these patients, you really need to be very aware of this, because for this patient, cardiomegaly would certainly be when they had a 50% cardiothoracic ratio, so you can underestimate it in these patients. Just while we're on this patient, because it shows it nicely, notice their right hilum is above their left hilum, and that's because they've got some fibrosis going on in their right upper lobe, and that's dragged that hilum up. All right, so we're going to move on and talk about the borders of the heart on the PA and lateral chest x-rays. So let's start first of all with the right atrium. So the right atrium forms the right heart border, but on the right atrium is going to be something like this. I'm going to show you some diagrams in a minute. But on the lateral chest x-ray, the right atrium does not form a border with the lung at all. It's actually en face, so we're not going to see it. Conversely, the right ventricle, which sits about here, we're not going to see bordered by the lung on the frontal radiograph, but it is bordered, because it's the most anterior chamber, on the lateral chest X-ray, and it comes up and fills up part of the retrosternal space. On a normal patient, if you draw a little, measure the distance roughly between the apex of the heart and the manubral sternal angle, the right ventricle shouldn't take more than about a third of it. If it does, that is right ventricular enlargement, so it's going to enlarge to increase that space. Let's move to the left ventricle. So the left ventricle forms the majority of the left heart border on the frontal, and it forms the inferior and posterior heart border on the lateral chest X-ray. Now, the left ventricle in normal patients shouldn't come back more than about, here's the inferior vena cava, this little curvy linear thing here. Shouldn't come back more than 2 or 3 centimeters posterior to the inferior vena cava. And as it enlarges down and posteriorly like this. And then our final chamber is going to be the left atrium. So the left atrium is the most posterior and the most cranial cardiac chamber. So it sits right in here, and we really only see the little left atrial appendage when it's normally sized. And then it's going to sit back here like this. So notice it is more cranial than the left ventricle. So when we're looking for enlargement, we're going to look for it to come back here. When it gets really big here, on the frontal, we can see it almost like a double bubble sitting behind the heart here. And as it gets bigger and bigger, it's going to lever up the carina, such it splays the carina like this to more than 90 degrees. And here's just a diagram of how the ventricles superimpose on the chest X-ray. Remember that we're seeing a 3D structure which is being projected in a 2D image. So just to run through these, we have the left atrium, the right atrium, the right ventricle, and the left ventricle. And here, left atrium, left ventricle, right atrium is the blue one here, and right ventricle in red. And here's just to show them on a CT scan. So here we are, right atrium, right atrium. Right ventricle is in here. Left ventricle is here, forming that border. Left atrium we don't see on this, so sort of a little tiny bit of the left atrial appendage just sneaking through here. This is the pulmonary artery. Oops, P. And here is the ascending aorta. So, and we don't see the ascending aorta because it has no interface with lung. It's only got interface with soft tissue. And now just to show you that correlation with a sagittal CT. So here we have right ventricle. Right ventricle is going to be there. Left ventricle. Left ventricle is going to be there. Left atrium. Left atrium. And then we have our aorta coming up. And we're not seeing the not seeing the right atrium in this. Because that's on the other side of the heart. And here's our pulmonary artery coming out, and here is our pulmonary artery coming out. Now, the important thing to notice in the front of the heart is that we have 3 bumps. We have the right ventricle, we have the pulmonary outflow tract, and then we have the ascending aorta. Right ventricle, pulmonary outflow tract, we're just a little bit off sagittal for that, and then the ascending aorta. Here's that left atrium. So as I said, you've got your carina, and the left atrium sitting under it. So as it enlarges, it will lever up that carina. Here's an axial image of the left atrium, sitting back here. Remember I said it was the most posterior and the most superior of the chambers. So here's the left atrium, here's the ascending aorta, and this is just a little bit of the pulmonary artery, or the pulmonary outflow tract here, and that's the descending aorta. So it's posterior, and it lies against this structure here, which is the esophagus. So it's immediately anterior to the esophagus, and that will become important in a minute. And this is just a slice a little bit lower down on the right. So this patient has a big right ventricle. Look how that takes up way more than 50%, way more than 30% of that distance. And they have a big left atrium, but they don't actually have a particularly big left ventricle. So if you guys remember your cardiology, this is a patient who has mitral valve disease. In this case, it was rheumatic valve disease. Remember how we said that the left atrium immediately abuts the esophagus? Well, this is a slightly oblique barium swallow from this patient. You can see how the esophagus takes this big swoopy back at the level of the left atrium because of this giant left atrium. So sometimes we diagnose left atrial enlargement on a barium swallow. I'm just going to run down the cardiac chambers on a series of axial CT scans before we look at the valves, just to make sure you know them all. So left atrium, right atrium, so forming the right heart border, the ascending aorta, and this is the pulmonary outflow tract. We're just going down a little bit lower, a little bit more caudally. We're still in the right atrium, still got the left atrium, getting into a little bit of the left ventricle, and we're into the pulmonary outflow tract. Lower still, left ventricle, little bit of left atrium. We're probably sort of coming into the IVC here, right atrium, maybe IVC, and here is our right ventricle. Obviously that's descending aorta. Lower still, left ventricle, right ventricle. This is a coronary vein, and here we're probably pretty much into the IVC here. Alright, so let's think about where the valves will be. Well, the valves are going to be between the two chambers. We're ready on the chambers, so we should be able to work out the valves. So tricuspid valve is going to be between the right atrium and the right ventricle, so it's going to be something around here. Now on the blood is flowing this way, so we already said the right atrium is kind of on fast, we're not seeing it, but the tricuspid valve is going to be kind of sitting there with the blood coming out towards us. Let's look at another valve now. Let's this time look at the pulmonary valve. Well, we've got the blood coming into the right atrium, goes into the right ventricle, and then it's going to come out to the pulmonary artery here. So the pulmonary valve is going to be at the top end of the pulmonary outflow tract. It's going to be sitting right about here. We talked about having the right ventricle here, going into the main pulmonary artery here, so we've got to put our valve up there. Alright, now let's look at the mitral valve. So our left atrium is sitting behind here, but we've got our left ventricle here, so we've got to kind of join those two up. Got our left atrium here, we've got our left ventricle here, so we're going to put our valve right about in there. Right, it's got to flow between the two. And if you think about the orientation of that valve, it's going to be, the blood's flowing this way, so it's going to be on edge from this projection, but it's coming out towards us from the back to the front of the heart on the frontal, so therefore it's going to look more like a circle. And then finally we have our aortic valve. The aortic valve is easy because it's going to be right in the middle of the heart. We've got our left ventricle here. We need the blood to go out to the aorta, so it's going to be right about there. And we've got our left ventricle here. Blood's got to go out to the aorta, so it's going to be right about in the middle of the heart on both images. Now, the most common two valve replacements, aortic valve and mitral valve, and there's a quick and dirty for this to tell which is which. So if you bisect the heart following the same angle in both images, the aortic valve is going to be on or slightly to the left of that line on both of them, and the mitral valve is going to be down and to the right, like that. So quick and dirty. Here I put them all on the same place to give you an example. This is pulmonic. This one is mitral, tricuspid, aortic. Okay. So here's a patient who's had 3 valves replaced. Let's see if we can work them out. I'm just going to give you a couple of seconds to see if you can think about it from the prior diagram. Okay. Aortic, mitral, tricuspid, mitral, tricuspid, aortic. And I was delighted when a colleague sent me this chest x-ray, which the patients had all three. Now, remember, when patients' hearts get really enlarged, that they don't fall into exactly the places and I drew on the normal diagram, but still, we have mitral, tricuspid, aortic, and pulmonic. I don't know if this patient got a money off for having so many. There we go. And one last example, can you guess which two valves this patient has? It is tricuspid and pulmonary. They don't do the pulmonary very often because you can apparently do quite well without one. Okay, I think that's it. This is much more fun done interactively, but hopefully you've got a reasonable idea about chest x-ray anatomy. Thank you.